so there's different modes associated with it, and I'm not sure which company may have set it up.
Supplied me with a lot of stuff in the beginning.
In the beginning, yeah. So it may be something that you might want to try again, but it just depends. It does not work for everybody, but it does significantly increase your capacity or your lung capacity as well. Yes, ma'am.
Is this something that you're on 24 hours a day?
So, yes and no. No in the sense that you don't have to be on it 24 hours a day. Yes, you can wear it 24 hours a day. So we have several patients that wear nasal pillows, which are similar to your nasal cannula for oxygen, and they wear it throughout most of the day for at least 17 to 18 hours a day, because it does significantly decrease your work of breathing. So you can't wear it too much. You can definitely wear it too little, but you can never wear it too much, because the more you wear it, the more that your CO2 will actually lower, and you'll get that gas exchange going on.
That's another question. You said it actually exercises your diaphragm, so does it increase the strength and the lifting of your diaphragm, and also it increases your volume? Is that something that happens, and that actually it can improve things so that you don't need it as much?
Well, so most of, especially with COPD and neuromuscular disorders, most of them are progressive, period. So managing them and increasing the quality of life definitely is a positive towards it, but getting it to where you won't have to use it at all is highly unlikely. But it does exercise your diaphragm. There's different modes, like I was saying. You can use mouthpiece ventilation as well. So you can actually just take a mouthpiece and actually sip in air and get a volume of air down into your lungs. So there's lots of different things that they're capable of doing, and we work with our patients on all those different exercises to do at home. But as far as getting away from it entirely, that's probably not going to happen. But you may not have to use it as much, and you may be able to actually do more because you'll have more energy, and you'll get stronger with it as well. Yes, sir.
Just a question for you. I've asked, never got an answer, but do they make a machine yet that delivers more than 7 liters? One of those little oxygenators or portable?
No, sir. No, sir, not yet.
Not yet.
No.
They're working on it?
It's highly unlikely. So, yeah. Joe, so I'll take a quick aside. The oxygen market, it's kind of crumbled as far as the research that goes into home oxygen products. I'd be more than happy to talk to you about that afterwards. But yes, we've seen that over the past probably 5 to 6 years. Yes, ma'am.
I was just trying to get a fuller picture of how all this worked as far as like the breakdown. So COP360 Solutions, MedInc is the company, correct?
Yes, ma'am.
So this is a program?
Correct.
Okay, so can you kind of give the breakdown of like how do you get this? Is it by like a doctor's order? How do you incorporate? Is that what you're getting to next? Or?
Yeah.
Okay.
So
how do you incorporate the home health? Like, is it who does the medication management? Is it like a partnership? I'm kind of curious about all that stuff.
yeah, certainly.
Can I speak from personal experience?
Sure, go right ahead.
When I came home from the hospital a year ago, MedInc has a sister company called James River Home Health. And James River has been with me now for a year. The visiting nurse comes in about twice a month or every 2 weeks, more if necessary. If I have any issues, they will actually call my doctors and talk to the doctors about the issue, and they'll come to a decision, what needs to be done. My medications, they track, and again, they know exactly whenever I need a change in medication, they discuss that with the doctors. MedInc comes in for the Trilogy side and the respiratory side, but it all works together.
Yeah, so and Mr. Counts is exactly right. So the first the first thing that happens is we actually identify what patients are actually good candidates for the program. So it's not always everybody, but we work in conjunction with hospital systems, insurance companies, as well as physician offices to identify those patients that would benefit from this form of therapy and the program in general. Based on that, we always do an initial assessment. So we'll go out and assess the patient, whether it's actually in the hospital or in the pulmonary office or at home, and we collect clinical data. So there's a lot of things that doctors don't know in the office that we find out in the home. The patient may have a relative that smokes. You may have, animals, and you have asthma, but you don't want to give up your animals. So let's talk about how do we manage that. There's lots of different things. You have 2 ProAir inhalers. One of them you got when you were discharged from Chippenham, and one of them you got when you were discharged from St. Mary's. And I had one of our sweet patients. She had 2 albuterol inhalers, 2 ProAir inhalers, and she would take them one after another, right after another. And she said, the second one seems to work better. And I was like, that's because you took the second dose of the same exact drug. Which is great, and she was always very jittery, and I was like, well, that's probably why. So there's lots of those things that you just don't find out until you actually get to sit down with somebody and talk to them and actually see them in their own environment. So we do that as well, and then we actually engage. So we actually start therapy. We start the whole process. We engage with the patient's doctor, everybody involved in the care. So we do partner with James River Home Health, which Wanda and myself will be here afterwards, and Wanda can shed more light on James River Home Health as well. But they offer in-home occupational therapy, physical therapy, and nursing. And we offer respiratory therapy and in-home nursing as well. Yes, ma'am.
I don't totally understand the process, but do other home health agencies also work?
Yes, so we partner with lots of other ancillary offices and rehab facilities and home health agencies as well. So we have some patients who have Bon Secours Home Health. There's a couple of other ones around as well. We work a lot with Health South. They're generous enough to let us have our devices in their facility, which is nice. But yeah, so that's basically, so the process works. We identify a patient, they get enrolled into the program, we initially assess them, we get them started on any therapies that they may need, and then based on that, we manage. So you see the management right there. We have a software system that we use that each patient is entered into, and we grade certain values. So we actually monitor your oxygen levels, your in-tidal CO2 levels. We do home spirometry tests. How many of you have had a pulmonary function test, a PFT? They're pretty exhausting, aren't they? Yeah. So we do bedside ones at the home. It's a little bit easier, and then we will actually send those to the doctor to read as well. So all of those things we take on a monthly basis, and we enter those into a system that actually grades whether you're green, yellow, or red. Those are just colors that we use to grade that. But based on those gradings, we can kind of manage, how well you're doing in the process and how well you're doing in the program, and we can intervene at any given point as well. So Mr. Counts can call me on a weekend, and he can say, I'm having issues. And I'll say, all right, well, let's call your doctor. Let's see if we can get a steroid upped, and let's up your settings on your non-invasive, and let's see how you do. And so we'll send somebody out there, and we'll do all of that. For most, statistically speaking, most patients that are admitted into the hospital, for every day you're in the hospital, you lose about 3 days on the rehabilitation side. Just because you're laying in bed, you're extremely sick, and you're not doing as much, and so you lose a lot of that time. And so by staying at home and getting through an exacerbation that's not necessarily life-threatening, you actually could save a lot of time on the back end as far as rehab. Any questions about? Did I answer your question?
Yeah, part of it. I'm just.
So right now, most of the patients are identified in the hospital. So the pulmonary PAs and nurse practitioners that are working inside of these hospitals are familiar with our program. So they're identifying the patients. based on what their CO2 levels were on admission, if they've had multiple rehospitalizations in the last year, and really just their symptoms. So they're identifying those patients, and then we assess them to see if they meet the criteria to be admitted into COPD 360, and then we follow them that way. So not every patient that we have is on a device. We have several patients that are admitted into the program as maybe a stage 2 patient that we will follow during the progression of their disease and help them manage their symptoms as they go along.
And I'd be happy to answer any more detailed questions afterwards as well. So any other questions that you have. So this is just a screenshot of what the software looks like, but this is very much what we enter into our database. So it actually gives a breakdown of the summary of each individual. So you can see we monitor the SpO2 levels, the end-tidal levels, device compliance, that's with any device which you may have, respiratory medication compliance, as well as your pulmonary function testing. Any questions for me? And I'd be happy to go over more about the devices too afterwards. So.
I have some questions.
Yes, ma'am.
You said that Inc. was founded in 1999?
Right.
When did you all start the program, the COP 360 program?
About 4 years ago.
4 years ago?
Yes, ma'am.
And what doctor approached you and asked for you to reach out and help people like us?
Dr. Michael Polsky.
Polsky.
He's our medical director.
Correct.
Oh, okay.
He's with Pulmonary Associates.
Is there any, yeah, that's right. Now this Trilogy, why would Medicare not pay for it if it cuts down on hospitalizations for exacerbations and probably readmission rates?
Yeah, so that's a,
$1 million question.
yeah, well, so it's not $1 million question, it's actually a very funny question. So just in case Medicare Part A is the one that pays for your prescription drugs and your hospitalization stays.
Right.
Medicare Part B is the one that pays for your home care side.
Mm-hmm.
So Medicare Part B is the one who pays for these home care devices.
Oh, so they don't care.
They don't care. They don't care.
Okay.
It's not costing
Well, that
them.
sounds
It's
about
costing
right.
Medicare Part A.
Yeah.
So I'd love to talk to you more in depth after later, but the government has a hard time talking to each other about
Oh,
what
yeah.
they're doing.
Yeah. How about private insurances such as Federal, Blue Cross, and Blue Shield?
Yeah, so we don't have any issues with most third-party insurances
Okay.
as far as coverage is concerned.
Okay. Cool. Thank you.